Okay, thank you so much. Good afternoon to everybody. It's lovely to be here and congratulations on such a lovely meeting and conference. I think this sums it all up. If you want to see what this lecture is, just attend the conference. How to choose the patients, how to choose the medications. This is quite an important subject. And we have always thought that just controlling the blood pressure is more than enough, but sometimes we also need to choose which medications to which patient, and does antihypertensive medications with different or similar blood pressure control do have the same outcomes or not. As we all know, increasing blood pressure, whether systolic or diastolic, increases morbidity and mortality. And we have seen a lot of timelines in hypertension and hypertension-related trials with a lot of medications, not to go through them. There are a lot of medications. A quarter of any medications in the market are antihypertensives, whether in the single medications, dual medications, triple medications in one tablet. So we have a lot. So what to do, how to choose? Well, first of all, we want to control the blood pressure because we know mortality and morbidity do diminish when we control the blood pressure well. And all the data from SPRINT and others show that the most important reduction we see is mainly in heart failure, of course, strokes, myocardial infarctions, and death. So we need potent medications, and this is number one. And also, we need to go lower and lower, as we have seen from the data coming out of SPRINT and also from ACCORD in diabetics, that lowering the blood pressure to a target of 130/80 at resting in most patients does affect outcomes. So we need potent medications, and this is coupled by non-pharmacologically supported therapies. And controlling the rates is another entity that we're talking about. So we need potent medications that can control the rates. How can we do this? Well, first of all, the awareness of treatment and the control rates are very poor all over the world. And I quote Professor Mohsen saying that in Egypt, we have a very poor control rate of around 8% published years ago. But I know, taking into consideration the new cutoff points or the new targets, probably the control rate may be worse all over the world. But let's look at Western countries and more developed countries. The control rates are around 40 to 50%, whether in the United States. In Europe, it's totally a little bit different. It depends on the country. And the control rates actually show us that patients who are treated and uncontrolled have a mortality maybe even higher a little bit than the untreated patients. So another point, when choosing your medications, we want to go with strong medications that will control our patients. And the patients should be compliant on the treatment. And compliance has so many things to take into consideration. The number of pills, the more pills we take, the less compliant we're going to be. It doesn't differ in any disease, especially if the patient is asymptomatic like hypertension. Compliance goes really very badly down. So this is another important thing, that we need good medications which are potent, which will reach our targets without important side effects, and the patients will be compliant to it. And blood pressure control is improved with compliance, and so is reduction in heart failure hospitalization or hospitalization due to any other cause in any other disease entity with compliance. So a combination potent therapy is quite important in these patients, because we have more than one way of controlling the blood pressure, more than one way of cardiovascular protection, and this also will decrease the blood pressure variability that was lovely introduced by Professor Gamila in the previous lecture. Long duration of action medications that will reduce the blood pressure variability. But most importantly, when we talk about choosing the best medication, we are also looking for cardiovascular protection. And we know in hypertension, it's not a single disease. It has a lot of coexisting problems with it. It could be coronary artery disease, it could be strokes, it could be chronic kidney disease, diabetes, so and so. So hypertension usually is not just by itself, it usually is accompanied by a lot. And we have to stratify the patient's risk according to the level of blood pressure and the level of risk factors or establishment of diabetes, chronic kidney disease, or cardiovascular disease. And accordingly, the European guidelines stated, if the patient is not at risk at all, but he has a blood pressure, or she has a blood pressure above 160 over 100, he or she should take treatment, regardless of the risk factors. What if the patient has grade 1 hypertension or high normal blood pressure, but is at high or very high risk for cardiovascular disease? Regardless of the blood pressure, actually, he or she should take medications. Again, stratifying the risk of the patient is an important part. So, adopted since the ESC guidelines in 2018 is the single pill therapy. And this has been revised by the data on dual combination therapy, and not only how good they control the blood pressure, but how good they control also cardiovascular endpoints. Not all of them do this, and we've seen throughout the day different data from different medications, different combinations, but definitely the 3 most important combinations that were concluded by the ESC, or the European Society of Cardiology, I'm just quoting them because they're the biggest society of cardiology in the world, that RAS blockade, calcium antagonist, and a diuretic, especially of the thiazide type. These are the 3 most commonly prescribed, not only commonly prescribed medications, but these are the most prevalent cardiovascular reducing medication and protective medications. And to start off with, instead of taking one single pill, taking a pill that contains 2 of these molecules, be it an ACE or an ARB, calcium antagonist, a calcium antagonist and a diuretic, like just the lecture we've heard right now, or a diuretic and a RAS system blockade. Then, if we're not controlled, we should up-titrate to triple therapy, and thus accordingly to the patient's outcomes. But not all patients are the same. This is the case for a hypertensive patient with no constellation of risk factors or the usual hypertension with no compelling indications for other medications. What if the patient has coronary artery disease? The beta blockers, probably what the commonest written in our country, here are indicated. Beta blockers are very good medications to control heart rate, heart failure, tachycardia, but reduction of mortality in hypertensive patients without compelling indications is not being shown by beta blockers to a big extent. Okay, I know there are data with nebivolol that it is safer, but again, they were not up-titrated. Since 2006, with the NICE guidelines, beta blockers have been demoted to a second-line therapy, and this was also seen in the ESC guidelines of 2018. What if the patient has chronic kidney disease? And this is a very important thing, because some of us, be it cardiologists, nephrologists, we shy away from the RAS system blockade. In fact, RAS system blockade is very protective for chronic kidney disease, and you should be aware that chronic kidney disease, the #1 cause of death is cardiovascular ischemic heart disease, heart failure, and so on. So if the patient has a contraindication for RAS system blockade, yes, calcium antagonists, diuretics, but as you can see again, not beta blockers unless the patient has a strict indication for them. If the patient has heart failure, the reduced ejection fraction, not the preserved, we don't have solid data for preserved ejection fraction management, but RAS system blockade, not any RAS system blockade. The evidence, of course, is towards most of the ACE inhibitors and 3 of the ARBs, and certain beta blockers, especially the selective bisoprolol, metoprolol, nebivolol in Europe, not in the United States, and carvedilol, and these are the medications to control blood pressure in a hypertensive patient with reduced ejection fraction. Here, if we have a tachyarrhythmia, be it atrial fibrillation, sinus tachycardia, then we can choose the beta blocker as a drug of choice in the start. But again, as you can see, the European Society of Cardiology, quoting it as the biggest society of cardiology in the world, states we should usually go with dual combination. Why? Because as I started off, compliance, control rates, we're not really reaching them. If we want to get better control rates, better blood pressure controls, we should start with 2 medications in most patients. Of course, some patients will take monotherapy. How about looking at the whole spectrum of guidelines? And I think hypertension has the biggest number of societies worldwide and guidelines worldwide. And if you look at collectively the data from different guidelines, you can see there is a little bit of a difference on the targets, but not so big. If you look at 130, 140, just 150 in the elderly in the American Society of Hypertension, NICE in Canada, but actually the guidelines are really nearly to each other. But most of them say around 130 to 140. They agree that the most important 4 classes of drugs are the ACE ARBs, calcium antagonists and diuretics, if you look at what they agree upon, using single pill, long-acting medications, and trying to gain blood pressure control not over a period of 3 to 6 months. We're talking about a quicker period of 1 month or less. But they do have a little bit of discrepancies in beta blockers. They are not advised in most guidelines, but they are restricted in some guidelines. And Canada, even the 2021 CHEP guidelines, say we can give beta blockers, but not preferred over the age of 60. Again, another thing about drug combinations, again, they agree that multiple drugs are required, single pill. Again, I'm just trying to reiterate how important single pill therapy is. And without, of course, combining an ACE and ARB, this is deleterious, of course, to the patient. But there are some discrepancies on if we need more than one drug in the Canadian guidelines and Taiwan guidelines, what to combine according to the patient. And of course, if the patient has a compelling indication, say he's diabetic, chronic kidney disease, and so, there's no discrepancies whatsoever. So you see, single pill therapy with long-acting medications of the 4 classes of ACE ARBs, calcium antagonists and diuretics, are the #1 choice in most guidelines. And this has been shown to improve mortality and cardiovascular protection. We'll just skip that. Why is that? Because if you look at the data on prevention of certain cardiovascular disease, you can see in previous stroke, myocardial infarction, heart failure, you see the data is very positive, very good, very consistent with ACE ARBs. Yes, beta blockers here in angina, ischemic heart disease, heart failure, and myocardial infarction do have their data. But if we talk about left ventricular hypertrophy, microalbuminuria, renal dysfunction, still ACE ARBs, calcium antagonists and diuretics have that, with beta blockers having a minimal effect on protection in these subset of patients. And don't forget, another important thing about compliance in this asymptomatic deadly disease is the side effects of medications. And one important thing is we should understand that not all medications do have the same side effects. Of course, ARBs are probably the least discontinued according to this registry that included over 600,000 patients. But look after that, it's the ACE inhibitors. ACE inhibitors are very potent, are very important too, and have shown that their discontinuation rate is very close to that of ARBs. And of course, always keep in mind there are compelling and possible contraindications for certain medications in certain patients. So just to conclude, we're not just treating numbers, we're treating a patient with an increase in cardiovascular morbidity and mortality. Controlling numbers definitely reduces stroke, definitely reduces heart failure, definitely reduces mortality. But choosing the correct medication, in which I'm talking about a single pill from the start, in most patients, not all, having a RAS blockade, calcium antagonist, diuretic, 2 of these in the first initiation combination. Looking at further improvement of patients is looking at the patient's comorbidities and compelling indications, and following up the patients on a shorter period of time, not letting the patient for 3, 6, 8 months and then following up. And these are collectively the agreement of most guidelines. Thank you.
Thank you so much, Dr. Ahmed, for this elegant talk. Any question from the floor?
For sake of time.